So today we'll be discussing about a very interesting ECG. So you can simply try to pause the ECG and you can try to find out the problem. Now what we can see here, this is very clear cut that in here there is tachycardia. Here the heart rate is less and here the heart rate is more. It's very simple to calculate heart rate. It is 300 divided by total number of large square. So if you can see here, it is almost if so this is the one large square and this is the second large square, so there are two large squares, so the heart rate is 300 divided by 2, it is 150. So there is definitely a tachycardia, and we always have to remember the most important thing, that whenever heart rate is more than 150, usually the chances of arrhythmia is very high. Either it will be supraventricular tachycardia or ventricular tachycardia. It can also be definitely sinus tachycardia, where P wave has to be very, very clear. Now, in here, when we try to see, we will simply to call it as sinus tachycardia. We must see P waves before each and every QRS. So we zoom in and we see here that this is R wave, this is S wave, this is definitely T wave, which is inverted. But here we are not able to see any P wave. So P wave is not there. Here also P wave is not there. Here maybe P wave is there, but P wave is not at all very well there. So chances of it having sinus tachycardia is very less. So this is not at all a sinus tachycardia, because in sinus tachycardia we will see very well defined P waves here, but P waves are not there. So this is not at all a sinus tachycardia, because P wave is not at all anywhere. It's very difficult to find P wave because P wave is not at all there. But when we compare this with this ECG, we can very nicely see P wave. This is P wave. This is P wave. We can very easily make out that there is this positive bump is P wave. So almost here it is very well, P wave is here. So here P wave is here. So P waves are very, very well localizable here. P waves are there. So in here we can see P wave is here, P wave everywhere there, P wave is there. But in here we cannot see that bump or that P wave. So this is not at all sinus tachycardia. This is the first thing. So this will be either supraventricular tachycardia or ventricular tachycardia. So supraventricular tachycardia means the problem is, or the the tachycardia arises above AV node. Whereas when we call it as ventricular tachycardia, we call it as the tachycardia originates below AV node. So we know supraventricular tachycardia means above atrioventricular node. The QRS wave will be always very, very sharp or narrow. So this is the most important thing when we think about SVT versus VT, supraventricular tachycardia versus ventricular tachycardia, is QRS will be very narrow. Because when we call it as ventricular tachycardia, this tachycardia actually originates into ventricles. So we know that in heart we have SA node, then we have AV node, then we have this Purkinje fibers. So we know that this Purkinje fiber, they can carry the impulse very smoothly and at a very, very high rate. That is the reason why any impulse which comes from here to here is carried very fast from here to here. So this is ultra fast. That is the reason why this QRS is very narrow, because it is carried very fast. Least is the time to carry the impulse, shorter will be QRS. More is the time taken to carry out the impulse, more or wide will be the QRS. So, in ventricular tachycardia, which mostly occurs in elderly patients, or those patients who have heart attack, or those patients who have myocardial infarction or reduced ejection fraction, these muscles remain damaged. Because in myocardial infarction, what happens? LAD or RCA or LCX, these territories, these arteries get damaged. So this myocardium gets damaged. So not only the muscle get damaged, the Purkinje fibers also get damaged. That is the reason why the impulse take more time to travel. So the impulse has to travel from muscle to muscle because this Purkinje fiber network is damaged. So QRS is wide. So whenever we see that rhythm is originated into the ventricle, it means the QRS has to be wide. And when we say it has to be wide, we must have a QRS of more than 120 milliseconds because normal QRS will be lesser than 100 milliseconds. So 100 to 120 milliseconds, in short, 40 means one small box. So 120 means more than three small box. If it is there, we will call it as wide QRX. Now here, if we zoom in, we can see there is hardly two boxes. See this, there are hardly two boxes. This one and a half box. So QRS is not at all wide. So this is very narrow complex tachycardia. So in short, whenever it is narrow complex tachycardia, it is either sinus or supraventricular tachycardia. And when it is a wide QRS complex, then it is almost always ventricular tachycardia or supraventricular tachycardia, but with aberrancy. Means there can be some aberrant pathway which actually causes wide QRS complex. So here QRS is very, very short. Uh, there are a few more things which actually helps us to differentiate SVT versus VT is in ventricular tachycardia, usually you will see only one concordance means from V1 to V6, you will either get all the R waves or you will get all the S waves. So you won't get a pattern where QRS is predominant and S is predominant. Where in this SVT, we can see it is all S wave. In this R is there, S is there, which is very, very well localizable here. R is there, R is there, R is there. Here, S wave is here, S wave is here, and here it is equalization phase. So this type of differentiation is not seen in VT. In VT, what ventricular tachycardia, what you'll get all the S waves only in all the leads. You won't get QRS pattern. So narrow complex tachycardia, it is almost always never ventricular tachycardia. If it is wide, we always have to think about ventricular tachycardia. So I will tell about the drugs. The main discussion point of this ECG will be drugs. So in supraventricular tachycardia, the first and most important drug which is used is injection adenosine. Now, adenosine is a very, very, very short acting drug. It simply acts for less than 20 to 30 seconds. So it disappears from the circulation. It is said that this adenosine, once it gets into the coronary circulation, means once it passes left anterior descending or LCX, it gets disappeared from the system. So it only lasts for one coronary cycle. So even if this drug causes cardiac arrest also, it will be always temporary and the heart rejoins its pace. So it is considered one of the safest drug to administer. The most important thing is injection adenosine comes into 6 milligram injection, and this has to be given as proximal to the heart as possible. So intracath which are placed at hand, they are not preferable. Mostly at least intracath has to be placed at elbow, or central line is also preferable. So elbow or central line, we have to rapidly push the 6 milligram injection, which is followed by a 10 to 20 ml IV flush of anus. So most of the time the SVT reverts back to the normal sinus rhythm within 5 to 30 seconds. If it again goes to supraventricular tachycardia, we can repeat 12 milligram, and after that we can again repeat 12 milligram every 2 to 5 minutes if SVT persists. So maximum of 30 milligram can be given at one stretch. The other two drugs which are very extensively used for SVT is injection cardron. or amiodarone. It is one of the most safest drug. It is one of the most commonly used drug for supraventricular tachycardia. And if it is emergency, injection amiodarone 150 milligram can be given by IV push. Or if the patient is stable, if the patient has stable supraventricular tachycardia, we can give 150 milligram of amiodarone in 100 ml or 20 to 30 minutes. It can also be repeated again after 10 to 15 minutes if SVT doesn't revert back, or we can continue the infusion also of amiodarone. The dosage for that is 1 milligram per kilogram for 6 hours and then 0.5 milligram per kilogram for remaining 18 hours. And after that, we can continue tablet or we can switch to tablet amiodarone. So usually we give around 300 to 600 milligram of amiodarone per day in tablet form. So we can give 100 milligram thrice a day, or if the tachycardia persists, then we can make it 200 milligram 3 times a day as well. The third drug is injection dilzem or diltiazem. It is very commonly used drug. Diltiazem comes into 25 milligram injection, and most of the time what we use is we use 10 to 15 milligram. We dilute it into 10 ml NS, and we can give it very slowly over a period of a minute or two. The when most of the time when the 5 milligram or 10 milligram of injection diltiazem goes into the system into the blood over a period of few minutes, most of the SVTs, most of the supraventricular tachycardia gets settled. So this can be repeated up to 25 milligram, 50 milligram. Most of the time, 25 milligram is more than sufficient. And if the patient respond it very well to the diltiazem, we can switch to tablet dilzem, that is diltiazem, and we can use 30 milligram 3 times a day. We can increase it to 60 milligram 3 times a day, or we can use sustained releasing 90 milligram twice a day. So most of the time, 180 milligram of diltiazem is more than sufficient. Around 600 milligram of cardone is sufficient, and adenosine the maximum we use is 30 milligram in a single stretch. So one of the most important thing that I need to tell you is SVT versus VT. So in SVT versus VT, SVT is almost always seen in young patients most of the time, whereas VT is almost always seen in patients who are elderly, usually more than 50 years of age. And SVT usually heart remains almost always normal structurally, whereas in VT is extremely common in those patients who have multiple infarcts, myocardial infarction, dilated cardiomyopathy, or valvular lesions, or those patients who have reduced ejection fraction of less than 30%, or those patients who have remodeled heart, or those patients who have significant ischemic heart disease, very commonly in post patients with post myocardial infarction. So, usually, ventricular tachycardia can have a very good outcome, and so many ventricular tachycardias or supraventricular tachycardia, they are almost always stable. Most of them are very stable, whereas ventricular tachycardia is almost always unstable. So, injection lidocaine is one of the best drug which can be used in ventricular tachycardia, but lidocaine is not at all used in supraventricular tachycardias. So, drug is adenosine is used for supraventricular tachycardia, diltiazem is used, and cardone is also used. Whereas for ventricular tachycardia, most of the time amiodarone or cardone is used, diltiazem is used, lidocaine is used. So for now, this is all, and thank you for